Hello, everyone. Thank you for joining us for today's webinar, Advances in Artificial Intelligence in Breast Health, sponsored by Hologic in partnership with the RSNA. This webinar is one of many ways RSNA is reaching the radiology community to provide education and resources. Today's webinar will be recorded and available for free in the RSNA Online Learning Center, as well as the RSNA's YouTube channel. I'm Tom Geisbers, and I'm the Senior Manager of Medical Relations at Hologic. Hologic empowers people to live healthier lives everywhere, every day, through its extensive portfolio of innovative medical devices for diagnostics, surgery, and medical imaging. I'll just jump to this disclaimer slide for a second here. This presentation includes a pre-recorded webinar, followed by a live Q&A with our speaker, Dr. Terri-Ann Gizienski. Please use the question panel on the left to submit any questions you have. The chat panel is also available for sending instant messages, but the questions you submit will go into that questions section, and that's what we'll be choosing the questions from. Now I'd like to introduce our speaker. Dr. Terri-Ann Gizienski, MD, is the Chief of the Community Breast Division at University of Pittsburgh Medical Center. As a seasoned radiologist, she has previously presented on all breast imaging modalities, including stereotactic biopsies, ultrasound-guided biopsies, MRI biopsies, breast ultrasound, MRI, and digital breast tomosynthesis. She has presented throughout the United States and other countries such as Italy, Japan, and Korea. Her clinical interests include automated breast ultrasound for dense breast tissue and extent of disease in newly diagnosed patients, and all types of breast biopsies. And now we'll begin the webinar.
Hello, and welcome to Advances in Artificial Intelligence in Breast Health. I'm Dr. Terri Gizienski, and I am currently the Chief of the Clinical Breast Division of the University of Pittsburgh Medical Center. I'm going to give you a little bit about my background before we start. I went to medical school at Pennsylvania State University, and then I did a radiology residency at the University of Virginia and did a breast fellowship 1 year at the University of Virginia. I then went to several private practices and eventually ended up at the University of Pittsburgh Medical Center, where I'm now the Chief of the Clinical Breast Division. So today, what we're going to talk about is artificial intelligence, really trying to understand it a little better in our field, some of the applications of how we can use artificial intelligence in breast imaging. And in that realm, we're going to talk about how we can utilize synthetic images, and then also some of the advancements with utilization of artificial intelligence to allow us to decrease the overall number of tomosynthesis slices that we have. And then we'll finish up with Genius AI detection, which is a new and exciting part of what Hologic offers. And then we'll discuss the future of artificial intelligence. So I think one of the first things that I want to do is just pause and have all of us remember why we do what we do every day. Really, we do it for our patients. As we know, to do breast imaging, you really have to have the passion to really care for the patients. And it's a very special field, and I feel very lucky and blessed to have worked in this field now for over 20 years to help those patients through the journey of breast cancer. And, every day you are reminded what an impact you can make in another person's life, just with a handhold, just with a hug. And that's really why I feel breast, imaging is obviously so near and dear to my heart. And so we just take a moment to, really acknowledge, all of our patients who I feel like sometimes they've helped me more than I've helped them along the way. So the first thing we're going to do is talk about really what is artificial intelligence. And the idea, to some is certainly overwhelming, certainly scary. Some people feel like, what is artificial intelligence? And I think one of the big things we need to understand is that, we need to really understand what it can do for us and how it can help us so that maybe it can allow us to make better decisions, to perform our work better. So artificial intelligence really is helping machines to think like we think, like humans think. And there's a whole variety of what you talk about with artificial intelligence. And most people, when they talk about artificial intelligence, are talking about machine learning, where we train a machine to get better at a task, trying to allow it to make, help us make good decisions. And what's exciting is now we're into the realm with the Genius AI product from Hologic of deep learning, which really allows more layers and more precise figuring out exactly where abnormalities are. And it's a whole lot more information. And I think that's where it's really exciting to get into more and more of the deep learning to, again, assist us in our diagnoses. So again, deep learning really allows the machine, the algorithms can really detect patterns that we can't see as humans because there's so much information coming at us. And so the deep learning takes the pixel by pixel and really deciphers, as opposed to machine learning, which oftentimes just looks at overall characteristics. So it really is the next level after machine learning. And so, why is it important? I think, again, at the end of the day, what is our goal as breast radiologists? We want to find every cancer that we can, of course, but we also want to do it with a reasonable recall rate and reasonable false positives. Because, that's one of the things that we often get criticized is, we call all these patients back, we cause a lot of anxiety, we do all these extra workups, and we don't really, have a lot to show for it. And so if deep learning is able to help us really find better cancers with improved sensitivity and allow us fewer false positives, that's going to, again, improve our specificity. That's really the win for deep learning. So the idea is that it looks at a group of pixels. So it actually looks at all these little pixels, and it can help determine, is the lesion more likely to be cancerous or not? The other exciting parts are then it can look at how is it responding to different treatments. Is the cancer, is it actually responding to this type of chemotherapy, or maybe we need to switch the patient to a different type of medicine, different regimen that will allow better response to treatment. And then the last part, which I think is really where we're heading with a lot of this AI, is looking at really the genomic properties and really understanding, why certain tumors in certain patients act a certain way because of their specific genetic makeup. And I think that's really where a lot of this is going to explode in the future as we get more and more sophisticated at being able to determine, again, why if we give two people the same treatment, one responds and one doesn't. So I look at it as not really one against the other, but I look at the machine and man working together for the best for the patient. And the reason is, as radiologists, we get a lot of information and data thrown at us consistently. And so, we really have to be able to process and figure out what is, benign, what is cancerous pretty quickly. And so that is where I think artificial intelligence can help us make better decisions for our patients. So the other thing is, in our work, I was very lucky and blessed to, be one of the early adopters of tomosynthesis, and that was a great boost for us. However, it definitely slowed us down, and radiologists who were used to doing a certain volume of work, we quickly found that we were not able to keep that up once tomosynthesis was incorporated, because it was just more data, more information, more slices, more images coming at us. And so we want to see, can artificial intelligence help with our efficiency? And again, overall, our performance. The performance of the radiologist is obviously very key in how our patients do. So if artificial intelligence can help, that's going to be wonderful for us. And then looking also really at globally, not just necessarily in our little neck of the woods, but looking at, the other countries, looking at the United States, looking at places that maybe, how can artificial intelligence help us for these subset of populations take better care of the patients overall? And really, helping our patients take the best care of themselves and helping them understand maybe what is in their best interest. So with artificial intelligence, I think it allows us an opportunity to look at different ways to utilize it. And it may not be the same for every center. Certain centers obviously have their own little nuances in how they want to look through their workflow, take care of their patients. Are they doing anything for the patient? Are they doing any sort of risk assessment? How are they evaluating the breast density? Are they talking to patients about what they can do to, take better care of themselves? And I think artificial intelligence has a role that it could play in this realm. So some of the challenges of artificial intelligence is, we need to figure out how to make it flow into our current workflow. Because again, as radiologists, we want things to be easy, we want things to be efficient, we get into our patterns, and so we have to make sure it's not going to create an extra step that is going to slow us down or detract from our usual patterns of working. Also talking about making sure it interfaces with your PACS system. Because again, as good as the information is, again, if you have challenges with your PACS system and integrating it into your PACS system, that's kind of a deal breaker a lot of times of being able to utilize it. And so again, understanding, how do you market it? If you have these features, how to best, let the patient population know, let your patients know so that they can get, the improved care. And again, make all radiologists better. That's the goal. If all the breast radiologists, all got better throughout the world, that would be wonderful. We all know, in the breast realm there's definitely a big need for additional breast radiologists to be able to take care of patients. And, we know a lot of people who shy away from breast imaging for a variety of reasons. So again, if this makes it easier, maybe we can encourage some people who maybe had an interest but were nervous about, breast imaging to allow them to re-enter. So the idea also, again, is to certainly, decrease the misses that we have. If artificial intelligence can, help us in that realm, that's obviously a great benefit. So looking overall at breast density software, there's been so much, talk about how do we determine breast density? What do you use in your practice? Is there a consistent way to evaluate breast density? And, I always chuckle at myself when I read a mammogram one year and say I give it a heterogeneously dense, and then the next year I decide in my head I'm going to give it a scattered, and then I look last year and see who read it as heterogeneously dense, and it's me. So I'm sure, some of you may have had a similar experience. And so if we had more of a consistent way of really evaluating breast density, allowing us to see it quickly, I think that, again, would be a very good positive thing for our patients. And so there is Quantra, which is, a product of Hologics, which is very good at evaluating and determining breast density. It's very reproducible, which is, again, a very important thing. Again, better than radiologists. I think I, read one study and it said we only agree with ourselves, I think 1/3 of the time in terms of breast density. So not great results for sure. And then even between radiologists, it can be a challenge as to who's calling what density. The wonderful thing also about Quantra is that it is compatible with both the 2D images and also the tomosynthesis images. And so here's just an example talking about Quantra products, and the Quantra 2.2 is the newer version of the breast density, and the old version was based on the volumetric evaluation of breast density, and the new 2.2 takes into consideration pattern and texture. And so the reason we were going to talk about why that change is really because of the change of the BI-RADS. And the BI-RADS, edition 5 came out and they really wanted to focus more on pattern and texture rather than overall volume. And so, Quantra really aligns with how BI-RADS has moved away from the volumetric assessment into the pattern and texture, because they felt that was more important when you're evaluating and trying to figure out, again, whether or not we're able to identify lesions on a mammogram. So what we also really want to stress with the Quantra software is that it's immediately available on the workstation. So you don't need a separate server. You don't have to worry about, any of those issues that you may run into, but immediately you're able to see the breast density. And so again, understanding and really appreciating how breast density, can impact your reading. So the Quantra is, objective, reproducible, allows you quickly to see, results, which are very nice on the workstation. And so in terms of pattern and texture, people were trying to figure out, is it overall density, just the volume, or really the pattern and texture? And I think most of us who read really understand the difference that pattern and texture can have and how that can impact whether or not we're able to identify a lesion. So here's an example, and there is a little cancer here seen in the superior aspect of the breast. And you can see both breasts have, a 25 to 55%, breast density if you were to do it in this, second quartile by the old edition. And you can see, though, more of the breast tissue and density is centered right over where this cancer is. So again, if we're going by volume, they would be the same. However, if we're identifying and evaluating by pattern and texture, we can see that it's going to be more challenging to find a cancer in this focused area of breast tissue. So again, trying to figure out ways to help us streamline our workflow and really give patients, the information about their breast density so that they can make better decisions for their care. The nice thing also about Quantra is it can be integrated into the mammography reporting systems that we all have in our practices. So now we're going to transition a little bit and talk about tomosynthesis with the synthesized 2D imaging. And this for me was really exciting when we started talking about synthetic views. And so we all know that breast tomosynthesis obviously performs very well. It was a great advancement, and I've been around for a while, and I read film screen, and I went through the digital transition, and then I went through the tomosynthesis transition. And tomosynthesis was really wonderful, as we know, because it decreased our recalls and improved our cancer detection. And there have been studies out there, of course, that have been published, in JAMA, in many of our journals, for sure, that show the efficacy of tomosynthesis. We know it is superior with 2D than just 2D alone. And when you do both the 2D and the tomosynthesis, again, it's going to be more accurate for our patients. We can see areas definitely better with tomosynthesis again, just because we're taking away the overlying tissue. So those areas of distortion really we're able to see much better. And again, helping all radiologists across the board really perform better. So again, with tomosynthesis, you can have up to a 40% increase in cancer detection rate, invasive cancer detection rate, and then overall cancer detection rate up to 27%. And again, recall rates typically go down. And my own personal experience is that initially my recall rate went up a little bit with tomosynthesis because we were seeing so much more, and we really had to kind of reset what we were recalling. So initially mine went up, and then it did go down a bit. And the nice thing about tomosynthesis is that across all breast densities and age groups, it does better. And so some of us who went through the digital, transition, initially we were focusing more on the dense patients, but we know tomosynthesis does better in all breast densities, which is, again, I think really something that we need to recognize. And so where we started was back, once the Hologic was approved back in 2010, 2011 by the FDA, it really started with a single compression where we did a tomosynthesis scan first, the grid was retracted, and they did a tomosynthesis sweep. And after that, there was a 2D exposure where there was an exposure with the grid. So that was what we called the combination mode. And so the next step after the combination mode was the synthesized view, which again, I think really was an advantage for our patients. So what we did is we performed the standard scan, and it was quicker than doing the combination mode, which was a little bit longer because we had to do the tomosynthesis sweep and then do a true D exposure. So with the synthetic view, we get our tomosynthesis sweep, we take our 15 projection images, and we turn those into tomosynthesis slices. And then we create, from those tomosynthesis slices, we create a synthesized 2D image. And so together we use the tomosynthesis slices and the synthetic 2D, and that allows us to get a lower dose examination for our patients. And this is really available in any view. So you can do it in XCC views, full laterals, whatever projection you want. And so now what we were able to see is with the synthetic view, there were some advancements from earlier images, which were called the first generation. Then we went to the second generation of the synthetic view and had increased resolution, which we're going to discuss now. So being able to quickly identify the synthetic view is really easy. There is something, you know, on the image that tells you that it's an intelligent 2D image. And the idea is that you always read the synthetic view with your tomosynthesis slices. So it's not you look at one or you look at the other, you look at them together and it's a full study. And that allows us, that marker, to tell us that it's an intelligent 2D, tells us that there we know it's not the full field digital image, but it's the synthetic view. And the idea is we use the synthetic view instead of the full field digital mammogram. And the reason is we can really allow us to compare current and priors, and it's going to give us the important details from our tomosynthesis slices. And again, we use them together. The synthetic view, tomosynthesis view, we use together. So when we compare dose, because of course, you know, patients initially, when we started doing tomosynthesis, people were concerned about how much dose am I getting? Is it going to be too much? And really what is nice is with the synthetic view is that we're able to decrease dose significantly. And so both doses are well within limits of what we're allowed to, you know, perform on patients, but the synthetic view does really decrease our scan time and decrease our dose. So looking at how does it perform, we know that using the 3D mammogram and a synthetic 2D does better than a 2D alone. We are increasing our cancer detection and again, reducing our recall rate. So again, for all those reasons, we feel like this is really a good direction to go for our patients and utilizing the synthetic 2D view. So just as a comparison, when you look at the images, you can see the 2D, then the tomosynthesis slice in the middle, and then the synthetic 2D. And so here is a lesion that I think we can certainly appreciate much better on the tomosynthesis slice, which we expect, but look how well we can see it on our synthesized 2D view. It really does stand out. And so there have been, as I talked about, different versions of the hologic synthetic view. The intelligent 2D is the newest version. And that really, the key to that is that it is the 70 micron resolution, which is an improvement over the first generation, which was the C-View software, where the resolution was 100 microns. So many of us, myself included, started with C-View, and then we transitioned to the intelligent 2D. They both serve the same purpose, and again, decrease in exposure, decrease the time that the patient, you know, is in the room and the scan time, and then it allows us really to get good information from our tomosynthesis slices. So again, just comparing, I think the big thing, and I'm going to show you some examples, is the resolution. The 70 micron is, you know, better than what we started with the 100 micron. And again, the difference in scan time is the same, the angle is the same, you know, reconstructed time, all of that is really the same. So it's really the resolution. And so we're going to show you the advantages in skin line and the demetalling and just really the overall, what we call the more natural look. We also have improved the visibility of the calcifications with the synthetic 2D, the intelligent 2D over the C-View. The other really nice thing is the smart mapping feature, which we'll discuss a little bit, to allow you to quickly identify where lesions are on the mammogram. So again, the Clarity HD, the high resolution intelligent 2D, is the 70 micron. And so it's gonna give us a really nice picture and image for our patients. So again, just the comparison, we're now getting back to our original resolution with conventional full field digital, which was 70. With the C-View, we went down to, we increased to 100, and then now we're back down to our 70 micron, which is going to give you a crisper image. So the big things I think that those of us who went through the transition really notice are the skin line and the contrast. And I'm going to talk a little bit about my experience after I show you some examples, but those were the things that I really picked up on initially. And then also just the spiculations and the distortions. And the reason that is more visible is, again, because of the artificial intelligence algorithms, which were improved with the second generation. So this is a picture that really highlights the overall image quality. So if you look at the Phantom, comparing the first generation C-View with intelligent 2D, you can see how well you can see the resolution. Even the numbers here are more clear and crisp. So that, I think, speaks volumes to the improvement in the resolution. And again, just a nice example showing you how you can really identify some of these Cooper's ligaments and the fatty tissue and all that fibrous tissue is more sharp in the intelligent 2D software. Here's an example showing calcifications, and again, really highlighting the difference in the number, and the morphology of the calcifications is just clearer and more crisp in the intelligent 2D software. So the idea is that we're going to reduce background noise, which is going to give us a better picture, but we also don't want to lose the clinically relevant information. And then also blurring. Again, the imaging process techniques allow us to see better overall image quality. And so here is an example, again, showing how sharp things are. And, initially there was question, were there calcifications? You can see calcification here and here. And there was a question as to whether there were additional calcifications. But on the intelligent 2D, we can clearly see there are no calcifications. So image blur, again, just looking at the definition of the breast parenchymal tissue, you can see more sharp and clear. And then contrast in terms of overall contrast in the skin line. That is definitely something that was a huge improvement. And some of us struggled with the C-View, just seeing the skin line, and you're going to see an overall improvement. And this is one of the examples that, we would often see this gray area where the skin line was. And it was hard to sometimes tell, is the lesion in the skin or is it just under the skin? With the intelligent 2D, we can clearly see how sharp the skin line is. So that really took us back to what we were used to seeing. And here's just a highlight example. Really, we're losing where the skin line actually is. And with the intelligent 2D, you can clearly see how sharp and crisp the skin line is. And just the overall contrast. When you look at the overall contrast in the C-View versus the intelligent 2D, you see how much darker the fat is. And that's really more in alignment with what we were used to with our full field digital images back in the day. So artifacts. Artifacts are something we obviously struggle with, trying to see around calcifications, clips, surgical, anything that's put in there artificially. So the synthesized intelligent 2D really decreased that. And here you can see what we used to see oftentimes with the C-View was the streak artifact, we called it. And you can see how much it decreased in the intelligent 2D software. And the same thing, just a nice example of another calcification, reducing the artifact around it. So then moving on to the margins of masses and spiculations. Again, the intelligent 2D had elevated software and algorithms which allowed us to really improve the visibility of lesions. So here you can appreciate when comparing the C-View, this nodule, you can see more of the border around this nodule. and spiculations, again, very sharp and clear in the intelligent 2D. Here it's a little bit more challenging to see in the first generation software. And calcification cluster, again, very difficult to see in the C view, and we see them a lot more clear in the intelligent 2D. So overall, basically, better resolution, the noise is reduced, blur line, the skin line looks so much better, and just overall contrast. And again, those bright objects in the artifacts. So again, better for our patients, easier for us to find the lesions. So for my experience, what I did in our practice is we were trying to figure out how do we transition from the first generation to the second generation. And, you know, anytime there's a change, obviously, you know, we as radiologists get very set in our ways, for sure. And sometimes it's hard to sort of push us out of our comfort zone. And so what we decided to do was to go really all at once to transition our unit so that we had sort of a start and stop point so that we got used to it pretty quickly. And again, you know, sometimes it takes time, and sometimes you may not be in the situation where you can, you know, sort of turn all of your machines on at the same time, depending on your practice. But I think the sooner you're able to do it, the quicker you're able to start adjusting your eyes. Now, I will say our transition from the combo mode to the C view was a little bit slower. We were a little bit uncomfortable. We weren't sure. We were like, are we going to be missing things? Do we not feel like we need a true 2D, you know, full field digital image? And so for a while, we did do the combination mode for our screening patients. And so then we decided to look pretty critically and say, you know, are we missing anything? Are we calling something that maybe we're not seeing on both images? And so we did, you know, a study. We had each of us look at the images without the full field digital, just using the synthetic view, and then together and recognizing, were there any lesions that we weren't seeing? And so we were able to quickly identify that really we were not changing our calls. We were calling the same things. The 2D was not really adding any additional information, or we were not losing any additional information by not doing it. So we then transitioned into just doing the synthetic view for our screening mammograms and, you know, for our diagnostics now too. So now I'm going to switch gears and talk about the 3D quorum, which is, again, super exciting. I was very, very excited when I first saw this technology, and I wanted to get my hands on it. And I remember saying, you know, how soon can we get it? And I'm going to talk about some of the reasons why and the advantages of the 3D quorum. So again, using artificial intelligence, we are going to be able to create these 6mm, what we call smart slices. What's really nice is the smart slices are going to have an overlap, which allow very smooth scrolling and not losing any information. Because again, at the end of the day, we don't want to make something better or make it more efficient for us, but yet we're losing information. So the idea is that the AI, again, is going to keep all that data and preserve all the information we have for our abnormalities, but yet give us a decreased number of slices. That's really the advantage, in addition to reducing our file size. And the idea is the smart slices are really meant to take the place of our 1mm tomosynthesis slices. So overall, wanted to look at, can this really help read times? Again, you know, the big complaint about tomosynthesis is it takes longer for us to read. So if we could decrease that read time, would that not be a huge advantage? And then also reader fatigue. You know, I myself know, you know, if I have a tough case at the end of the day, it's often a little bit harder to get through as opposed to the beginning of my day where I'm more fresh. So we're going to talk a little bit about the 3D technology, the 3D quorum technology. And what we do is we take the tomosynthesis slices, we use artificial intelligence to really highlight areas that are of interest. And that's going to be highlighted on our smart slices. And it's going to really, again, as I said, preserve the abnormality. So we take 6 tomosynthesis slices and combine them into one smart slice. And that's how we get our smart slice. So we're going to talk about, you know, is this slabbing? People said, well, is this a slab? And this is not. because traditional slabs are not FDA approved. It doesn't reduce the number of images to review, so it's not going to help with your read time, and it's not using AI. Smart Slices do all of that and more. So 2/3 reduction in the number of slices that you have to look at. Overall file size is going to be reduced up to 50%, and that's going to save on average, if you're reading 8 hours, about 1 hour out of your day. And again, you know, how you spend that time, or, you know, what you're going to utilize. I think all of us would love to have a little bit more time in our day to do, you know, whatever, whether it's reading more cases, taking care of other patients that we need to take care of. So what we do is we take 6 slices and we combine them into 1 slice. We then use an overlap of 3 to allow us to generate the smart slices and really not lose any information, because we don't want to be taking all that information, combining it, and not having some overlap, which allows us to be very confident that, again, we're not losing information and we're preserving all of the features that we need with our smart slices. And there's a white paper and reader study that was done looking at really, are they comparable? Are they, you know, we don't want to do this and realize that maybe radiologists aren't performing as well. And then also recall rates. So on both areas, we ended up doing better and, you know, equivalent. So that's really important. Is, again, the average ROC curve went up for people who use the 3D quorum versus the standard, you know, slices. And again, the recall, we did better overall. So again, we don't need the 1 millimeters. We can just transition into the 3D quorum. So now some examples just highlighting how wonderful and beautiful these images are, and you're able to really, again, appreciate the abnormality better in these smart slices. And here's a blown up view. Again, looking at the definition and the spiculations of this mass, you can see them to better effect on the smart slice as opposed to the 1 millimeter tomosynthesis slices. And again, the idea is that the artificial intelligence allows us to highlight those areas that are abnormal and gives larger weights to those locations in the algorithm, so that you will then not lose the features of the abnormality and the spiculations and, you know, the calcifications. So here's a nice example also showing the comparison from the 1 millimeter tomosynthesis slice to the 6 millimeter smart slice. And the same thing with the calcifications. We are finding that we are able to see and visualize calcifications to greater effect on the smart slice as opposed to the 1 millimeter slice. So my experience with 3D quorum is we transitioned immediately from the, I should say immediately, which was, I think, 2 weeks. For 2 weeks, we sent both the 1 millimeters and the 6 millimeters to the workstation, because again, we wanted to do a comparison and make sure that we were comfortable, weren't losing any information. Honestly, about after 2 days, I was ready to just say, forget it, just send me the smart slices. But I wanted, you know, the others in my group to be as comfortable as I was. I would encourage you to just make the transition, which I told others is, you know, please just think about just going right to the 3D quorum, because what happened was I had the 1 millimeters and I had my smart slices. So I felt like I had to look at both of the data sets, which in fact was not saving me any time. So I'm like, geez, oh man, I'm actually doing more work than you know I was expecting. So we then quickly transitioned. The other thing that I did do with my 3D quorum is I slowed my cine speed down, because there were fewer slices. I wanted to make sure, and there's more information I felt like on every single slice, so I slowed my scrolling speed down so that I was able to capture all of those abnormalities. But again, quickly was able to transition to the smart slices. So now I'm going to show you a couple of cases. This was a 54-year-old female, and she has a very, very dense breast here. And there's an abnormality here in her left breast in the lateral aspect. And just comparing the smart slice here on the left with the 1 millimeter, you can see how much sharper the area is and the spiculations. And there's a blown up view, again, just highlighting how well you can see these lesions. And here's her medial lateral blight. And again, a blown up view of the area of abnormality. And again, the skin line definition is even better in the smart slice. And that turned out to be invasive ductal carcinoma. Our next patient is 58 years old. And here is her mammogram. And on her mammogram, we saw an area in the medial breast. And again, comparing smart slice and looking at the overall texture, adjacent tissue, I think you can see it to greater effect on the smart slice than you can on the 1 millimeter slice. And here is another projection of the same lesion. And here's the lateral projection, again, showing and highlighting, really being able to appreciate the mass and the margins. And that was an invasive lobular carcinoma. Next patient, 72-year-old female, came in for her mammogram, and we were able to see this little nodule here. And I'm going to show you comparing side to side here, again, looking at the smart slice versus the 1 millimeter. And again, on our medial lateral blikes, blowing it up, looking at being able to see the margins to greater effect as where they're a little fuzzier on the 1 millimeters. And that was an invasive ductal carcinoma. Our next patient is a 48-year-old female, and her abnormality is in the right breast. And you can see this abnormality there. And again, highlighting the difference in the improved resolution with the smart slices. Invasive lobular cancer. Now we're going to turn to smart mapping technology. That uses the ability to quickly identify where a lesion is on your tomosynthesis slice relative to your synthetic view. And so again, allowing you to not have to scroll through all those images and really get to where you need to be. And then the Genius AI technology, again, is what I'm very excited to talk to you all about, because it does use deep learning. So we're going to find more cancers, going to allow us to be more efficient. And the difference in this type of artificial intelligence product is that it is a concurrent reading workflow. So the images come up as you're looking at the case, as opposed to traditional CAD, which a lot of us are used to, where you hit a button and you can see it at the end of your case. There is a study that was done, of course, and it did show that for all radiologists, regardless of their experience, all radiologists did better. So again, this is important information that it can help all radiologists perform better. And it was a multi-reader, multi-case study. And again, 2 sessions with washout period, very well. And it did show, again, better performance for all radiologists. The nice thing about this Genius AI technology is that it can be used different based on your practice. There's a lot of information that's available, and so how you choose to use it is completely up to you. It gives you things such as a lesion score, an overall case score, a reading priority indicator, a case complexity index, and then a read time indicator. So again, being able to implement this into your practice in some fashion is really going to be key to how you utilize it. So you're able to quickly get a lesion score, which tells you basically, compared to all the algorithms that were utilized in this artificial intelligence product, how confident that a suspicious area represents a cancer relative to the other lesions and throughout the algorithm. The reading priority indicator also, again, if there are multiple findings, if there's something very concerning, it can give you a higher reading priority. So again, you could potentially utilize that in a different fashion, so that maybe you do the higher priorities earlier in the day or while the patient's there, rather than at the end of the day. And the read time indicator is also something that, again, you can potentially use in a different fashion, so that if this case may be very complex and take a little more time, you may want to put aside different time as opposed to early in the morning or later in the day, depending on if you batch read. And case complexity, again, if there are multiple findings. So again, you can sort those cases if you feel like maybe I don't want to deal with multiple findings right now or at a certain time in the day. And then the K-score, again, how confident the product is that there is a cancerous lesion in that case. So we're going to finish with a couple of cases. The first one is a 57-year-old female, and here is her mammogram. And on her mammogram, she has a lesion that is marked, and you can see quickly that there is a K-score given to this patient. So then it is up to you again to really look at it. And what I really want to stress is through the algorithm, the idea is that we are going to improve our sensitivity. So we're going to find more cancers, which make us more accurate. But overall, the algorithm decreased the number of false marks by a factor of 4. So again, we are used to so many marks and so many, mammograms. This is really going to help us minimize the number of marks and really pay attention to, relevant abnormalities. So again, just showing you how quickly you can see a number and the area you can have the overlay so that you can identify whether or not the area does need to be evaluated. And it will quickly also take you to that slice on the tomosynthesis stack where the abnormality is. And that is the little mark here in the middle that allows you to know where in the stack it is. And that turned out to be atypical ductal hyperplasia. The next case is a 48-year-old female, and here is her mammogram. And there are several lesions. So again, it's going to give you a lesion score for each lesion that you will then figure out and evaluate and determine whether there's something there to work out. And again, just seeing how you can see it so well on the smart slices as opposed to the 1 millimeter tomosynthesis slices. And again, pointing, to the lesions, whether you like the overlay or whether you like just an arrow to show you the abnormality. And then again, you get to determine the workup. And the first lesion was an invasive ductal. The second lesion was a radial scar. Next patient, 58-year-old female. Here's her mammogram, and there are several areas that were marked on her mammogram. And here we can quickly see, again, the lesion score for these areas. And then again, we can determine, some of these areas may have been present before, so we don't feel like we need to work them up. And then other areas, maybe we do want to investigate further. So in this case, we can quickly identify, where the lesion is on our synthetic view and then on our tomosynthesis slices to be able to evaluate it. And that turned out to be bilateral carcinomas. Our next patient is 57-year-old. She came in with a palpable lump, but we saw something also, I should say, the Genius AI found something on the contralateral breast. And there you can see that little spiculated area. And that turned out to be bilateral invasive ductal carcinomas. Our next patient is 67 years old, and her mammogram here shows an abnormality. And again, looking quickly to be able to identify a K-score that you can toggle on and off to evaluate and determine whether or not you decide to biopsy it. And that turned out to be ductal carcinoma in situ. So Genius AI, I'm very excited about how you can utilize it in your practice. I think there's a lot of opportunity to help with workflow efficiency, to help with all radiologist performance, to make all of us better, to make sure we're not missing cancers, but also decrease the number of biopsies that perhaps we're recommending. So the end of the day, I think AI is going to play a large role for us. And I think we need to really look at it, try to embrace the advancements, try to figure out how in our practice we can make it work to the best of our ability. Thank you so much for your time. I'm now going to take some questions and answers.
All right. So we've heard from Dr. Gizienski on the advances in using artificial intelligence for breast imaging and improving diagnostic accuracy with Hologic's newest technologies, 3D quorum and Genius AI detection. Thank you so much, Dr. Gizienski. That was wonderful. We will open up the discussion for live Q&A with Dr. Gizienski. Again, the questions, we've had a lot of great chats, and the questions can go into the questions box, but we encourage you to submit those questions if you haven't already. And Dr. Gizienski, we'll turn it over to you.
Thank you, Tom. And I just want to also say thank you all for taking time out of your day. You know, we're all busy, and, you know, I appreciate RSNA and Hologic partnering to allow these events to happen and to share knowledge. So we have a bunch of great questions. I'll try to get to as many as I can throughout our Q&A period. And please feel free to definitely, you know, add questions. And the first question is, are you totally comfortable not using the 1 millimeter slices and relying on the smart slices with the 3D quorum for your screening and your diagnostics? And so the answer is yes. The Hologic reader study demonstrated there was equivalent performance between the 1 millimeter and the 6 millimeter slices. And the 6 millimeter slices are FDA approved to be used alone for clinical use. So definitely very comfortable with it. And one of the follow-up questions was, you know, did I do any sort of formal evaluation? And we did. What we did was we had our radiologist actually look at the images, make a diagnosis or make their, you know, assessment on the 6 millimeters and write that down. And then we went and gave them the 1 millimeters and had them write them down. Now, again, not super scientific, but just wanted to be sure we all were comfortable before we transitioned into just using the 6 millimeters and getting rid of the 1 millimeters. And so we definitely did that, noticed, you know, we really weren't changing our readings, and that's why we were comfortable. And I will tell you the other big advantage we noticed in our system personally is that because of the change in the file size, it made a big difference in our speed. And that was also something that was really, you know, to our practice, very advantageous. Now, you all may not have some of the same issues in terms of speed and file size, but we definitely noticed a difference. And, you know, I've talked to other people, some people, you know, have said they don't have issues with slowness or too much volume, but in our system, we definitely noticed a difference. So one of the other questions I had is Quantra compatible with its synthetic 2D? And the answer is yes. The Quantra is used with the synthetic 2D and the tomosynthesis slices, so you can use it for that. Next question that we'll see is a question about CT of the breast. Is it coming as a good choice anytime soon with reasonable dose? And I personally know there are ongoing studies, some of which, you know, I've talked directly to people who are involved in it, and they do feel is that it's coming along. You know, not sure what the time frame is. I think, you know, anytime we try to, you know, make these improvements, there's obviously a lot of things that go into it, and we have to make sure, of course, you know, we're making the best decisions for our patients. So I think it's not completely figured out. I think there's a lot of, you know, new interest now in contrast mammography rather than the CT of the breast. And so I'm not sure exactly what direction, you know, everyone will pivot to really decide, you know, where we're going. And then there was a question about the TMIS study. The question is, why is all this continued effort going into the TMIS if DBT is proven to be better in all categories of performance? Should they halt the TMIS? And so the TMIS study was set up back in July of 2017, and they wanted to accrue 10,000 patients and do the thorough evaluation. So we're almost to the end of that 5-year time frame. That was their sort of goal. And I think, you know, really seeing all the information that most of us have, I think everyone sort of agrees. And so I think, you know, we're sort of at the end anyway, so I think it's going to naturally just sort of play itself out. Now, that being said, I will tell you some of the latest figures that I have seen is that we have about, of all the radiology facilities in the United States, about half of them are tomosynthesis. So we still have about 50% of the facilities that are not tomosynthesis. And I think, obviously there are barriers, the first one, of course, being cost to the facilities to engage in, moving from, to the tomosynthesis. And I will tell you personally, in my area, I'm kind of surprised, but there are 2 facilities that are still doing film screen. So I feel very fortunate that in my facility, we were, one of the early adopters, as I talked about, with, digital breast and tomosynthesis. And I feel lucky every day that I have that technology, but many places do not have, some of even the digital technology available. And I think, as a breast care provider, we need to make sure we are out there recognizing, pushing, acknowledging, educating our patients. That's one of the things that we need to educate our patients. We also need to recognize, as a public health problem, how are we addressing this? How are we going out and educating those individuals, and also our referrers, the family doctors, the OBGYNs that are sending us patients. We need to really make sure we are educating them in what is happening, what is the technology, and how we can provide the best care for our patients. And a few more questions. So one of the questions is, why do different radiologists read breast density differently? And I think that's a great question. And I will tell you that it's very challenging oftentimes to really get a real flavor or idea as to how dense is this breast. Many of us do very well with the very fatty breast, and then the very, very dense, extremely dense breast. But those ones in between can be challenging. And I myself have found myself where I will look at the mammogram and feel very comfortable that this is a scattered breast. And I look, last year they read it as a heterogeneously dense breast. And then I look at who read it, and it's actually me. So we know radiologists, there was a study done that showed we agree with ourselves about 60% of the time. So we need to understand that, we still don't necessarily even agree with ourselves. And so that's why some very consistent way of evaluating breast density, I think, is a huge improvement for us as, again, healthcare providers, providing the best care for our patients so that they can make informed choices. In the end, we really want to talk about helping the patient make choices that they can live with, and, the choices that make the most sense for them. It doesn't have to be one size fits all. As we know, now more and more of us are trying to help patients understand what supplemental screening can look like for them, what it means in terms of, their care, the pros and the cons. And so again, educating our patients, educating our referring physicians is really part of our role, rather than just sitting down, reading mammograms all day. All right, let's see what other questions we have. Okay, so one question is, during the transition from the old to the new generation of the imaging system, was there any performance degradation of the AI CAD algorithm? And if so, how do you tackle those problems? And really, there is no degradation of the CAD algorithm. In fact, I think it actually, improves. And that's the wonderful thing. Hologic has invested, obviously, in making sure they really put the time and effort into getting these deep learning algorithms, as opposed to some of the earlier algorithms that weren't as sophisticated. And so the more neural pathways that you have, the better it's going to be for our patients. And that's one of the things that I really wanted to highlight is the reader study for the Genius AI took 17 radiologists, and they had almost 400 cases, and they did 2 sessions with a washout period. And they noticed that in all radiologists, regardless of their experience, we had an increase in the ROC curve, meaning they performed better. And we also had increased sensitivity by about 9%, which again is significant.
40 seconds, Dr. Gizienski.
Okay. Sorry. And so the last thing is that it also, I think one of the big bonuses is that it decreased the number of false positive marks. the number of marks by a factor of 4, which again is one of the criticisms that people have oftentimes, that, CAD marks so many things that are really nothing.
And we'll have to stop there.
Okay.
Thank you so much. I'd really like to thank Dr. Gizienski for sharing her expertise. To our audience, thank you also for attending today's webinar, and we hope you have a wonderful rest of your day. Take care. Thank you.
Thank you.